Now it's time for questions. Anybody, please? Right.
Can I ask one question to Bent? It's a chance that we have you here today. I would like to ask you, for example, there is an approach of hip arthroscopy that you made two small capsulotomies, linear capsulotomies, one for the central compartment and one for the peripheral compartment. And I mean, if someone is trying to be very conservative and really make them quite small, do you think even at this occasion he had to repair the capsule?
Yeah, it's a good question. I don't think anybody knows, but I know you all know Mr. Tony Andrade from Reading in the UK, and he is doing multiple small holes to gain access to the various parts. So it's not closing them as far as I know. I think if you're staying close to the acetabular rim and you want to do a capsular repair, do a labor repair, sometimes you cannot get around the corner properly, so then you have to make more holes. So I just decided to do interportal cut, and then you have to close it, I think. If you only make small holes, I don't think you have to close them, because for 10 years or more, we didn't close the capsule. And the evidence out there is, I would say, it ups in the direction of closure, but it's not clearly definitive yet. Of course, if you do a large T-cut, I think you should do it. But if you have a small hole or two small holes or a small interportal, I think you might be safe.
And if you do a T capsulotomy, how many sutures would you use?
I would use if you have like I would put them with 5 millimeters in between. So if you have a larger one, you have to put more. Actually, I did a T-cut yesterday because I had a young boy with loose bodies, a lot of loose bodies, and I had to go down and do synovectomy. And then I put two sutures on the T part of the capsulotomy. Right. So you have to be able to do it.
Mr. Lund, may I ask you another question, please? I know that you may not deal with arthritic hips, but in case with a young patient who suffers from mild, low-grade arthritis of the hip, would you consider closing again the capsule?
Again, an excellent question, because sometimes you have let's say a 28-year-old male, they're all males in that category, where they have a cam. You have a grade 4 change about 2 square centimeters on the lateral rim. You do a debridement of the cartilage. You have you do a microfracture or whatever, and they are stiff. You can hardly get into the joint. I don't think it matters if you do a capsular closure there.
Right. Thank you very much.
Can I say something on the registry, please? Because Chris did an excellent job, and actually he said that the results are secret, but you can talk about them. The only thing is that we are just putting the finishing touches on the annual report, and it'll probably be out in a week or two. Then it'll be available on the Danish Orthopedic Society's website. You can go there and have a look at them. So I would just like to thank the opportunity and that you took the time to show results from the registries, because I think they are important, both the Danish one and the UK one, because now we're gaining more and more knowledge on how patients dealt by various surgeons, not only the high volume Vendôme, Philippon type patients, but also from surgeons that do a lot of other stuff besides doing hip scopes. So thanks a lot for sharing that with our colleagues.
Thank you very much. May I ask Professor Poultsidis about pincer resection and labrum? When do you do the pincer? Yeah, of course. When you remove the pincer, do you always feel that you have to do a labral repair? I mean, do you try sometimes to go behind the labrum and to do the resection without annoying too much the labrum, or you consider that you should always then repair it?
That's a very good question. When I do the pincerplasty and there was no ossification of the labrum, I always repair the labrum because in a much way it increases the volume. And then I have the ability, as I mentioned, to invert the labrum and give more space during flexion and internal rotation. So unless it is ossified, then I remove it completely. I will always repair it.
Sorry. In case that you need to replace the labrum,
Yes.
what's your ideal graft, if any?
I saw you a case with just getting a rotational flap of the indirect head. If it's approximately 2 centimeters, you can cover it. No more than 2.5 centimeters. Ideally, I've taken several times the hamstrings, but I did open surgery, so I can go all the way around and make sure that I don't get any perforation with the scope. It takes less time. With the scope, it's more time consuming, and I use the hamstrings, gracilis in particular.
Thank you very much.
Autograft.
Another question for Bent. You said, Bent, that usually you do linear capsulotomy. Do you feel that only with linear capsulotomy you are able to remove some large cam lesions, or in these cases you have to do a T capsulotomy? Is it enough, the one linear for both central and peripheral compartment, you think?
Yeah, I think because when I put the suture, the capsular repair suture on the anterolateral portal side, I can actually pull out the capsules to make my access down the lateral neck a lot easier. But it's not. It's a difficult part of the surgery because you have to come way down on the lateral neck, especially. Medial, I don't think it's that much of a problem because you can flex the hip more and you can externally rotate it towards you so you can get easy access. So I think it's the lateral part that is difficult. And actually this holding suture or the capsular suture has helped me pulling the capsule a little bit away from the side. So I can get down there with an interportal cut. Very rarely I have to do a more extensive T-cut, but on the other hand, I've done this for 20 years now, so it's I think it's for a guy starting out. It would be maybe advisable to put a small T-cut and maybe put a holding suture on the corners just to lift up, as described in the literature.
Make it slightly longer. And it goes slightly more distant. That gives you more access. You can flex more the hip. Using that, that stitch, you may get access to the peripheral. That's the tip also. We're not doing the T-cut.
Okay, very nice. And Chris, I would like to ask you, you said that it was 70% satisfaction of the patient, which is a little bit lower of what we traditionally knew, that it was around 80%. And the next, also, I thought in these registries, they see the results in 2 years and not after that. Or may I be wrong?
The British registry goes to 2 years. The Danish registry aims to go to 10 years.
Okay.
So that's what I found fantastic with the Danish registry, because they are now giving us 1,200 patients with 5-year data. So in the conversation with our patients and trying to give them a realistic expectation, I'm sure if you are in a market-driven relationship. Let's call it like in the States. You have to sell them 100% success rate, which I think is unrealistic. If you have your gallbladder out, there's nowhere near these figures. But we all say you're going to have your gallbladder out, you'll be fine. Yeah. So I think we can now be honest with our patients about what realistically they can expect. And I will say to my patients, if it's 70 or if it's 80 or whatever your particular one is, that if you have a cohort of patients which is completely heterogeneous, as Ben said, you have Ben that does 1 million per year and I do about a handful, but still, if you put them all together, the minimum you can expect is 70%. I think that's robust data. And therefore, if you compare that to knee arthroscopy, where there is no data, for decades, and you can, I'm sure, challenge that. But actually, if you take a meniscus out, we heard yesterday some very good papers that talk about, actually, have we overdone it for a few decades? Well, now this is a particular cohort of patients and experts who are giving you fantastic data. And I think you can look a patient in the eye and say, 70%, that's fantastic. I don't know if you all agree, but for me, that's my take-home message from the registries.
Thank you very much.
Yeah, I think fair. There is a microphone there, Lazare.
I'm very cautious on doing any surgery regarding the iliopsoas. So I was surprised to see the data about, telling us to do more surgery. Is there a subgroup that was very well, studied, or can you give us more information? Because I know from my patients that either they love you or they hate you if you cut the psoas. And there are several ways of dealing with the psoas. We have iliopsoas impingement. We may have dysplastic hip and be another problem. Maybe we should reorient the acetabulum. Do you have any more information on that? Because personally, I'm very cautious.
Going back, that's a very valid question, and thank you for that. And I haven't got the answer. But what I do have through the registries, which was my talk today, is that there is a whole lot of patients, so 110 consultants in the UK, and I don't know if it's about 15 or 20 in Denmark who are very specialist in their field. So again, a heterogeneous group. They've got a great interest in psoas. So there's got to be something in it. There is some background, and there's some people who are very specialist in their field who, according to the registries, deal with it. Now, the data, I can't tell you. But what I find interesting about it from the specialist point of view is that somebody like you who does them regularly is not sure whether you're underdoing it or you're overdoing it by dealing with it. The only pearls of wisdom I have for you is that in my department, where my consultant colleague, who's the hip surgeon, the senior hip surgeon, and who just retired, he had done, I believe, sort of 2 or 3 iliopsoas tenotomies in his career, and they all failed. Whereas the ones I've done, which is another 5 in the years I've been there, they all succeeded. This is not my success rate, but it is how a soft tissue specialist may be seeing what psoas pathology is compared to. So I don't know if I'm giving you an answer, but your perspective in dealing with the soft tissue in primary arthroscopy, or as the registries say, post-arthroplasty, is probably stronger, better, more to the point, and probably you or somebody like you needs to be encouraged to do more of it rather than less.
Okay, thank you.
Can I add something on this matter, because it's I didn't hear the name of the colleague that asked the question, but it's a really good question, and I would say that the psoas tenotomy works quite well, really well, in the post-arthroplasty patients that have pain and limited hip flexion because of the psoas. That's a good indication there. I would be really cautious in a young patients with, let's say, a small pincer or something to do a psoas tenotomy straight away. You have to have done all the other work before you resort to psoas tenotomies, because I think in the young patients with no arthroplasty, it's a last ditch procedure in my view. Thank you.
Thank you very much, Bent. I think we have to close this session. Bent, it was a pleasure for us to have you here. Really, thank you. We may meet you in October.
No, I'm sorry, I can't come to Gaza, and I'm really sorry that I couldn't go to Thessaloniki, but I have some family business to attend to tonight. So, it was a great pleasure to talk to you all, and thank you for having me.
Okay, thank you very much.
Bye.
Thanks all the speakers, and we can move on to the next session.